Hello, everyone, and welcome. And thank you for joining us for today's webinar titled Assessment and Support of Preschoolers with Prenatal Alcohol Exposure. And so just for your information, all participants' microphones are muted today. So if you have any questions, we ask that you please use the Q&A box that is located at the bottom center of your Zoom Windows taskbar. The chat box is available for you if you have any comments or technical support questions during the presentation. And we'll be dealing with the questions sort of at the end of the webinar. As a reminder, this webinar is being recorded. The recording will be available on the Saskatchewan Prevention Institute's website and will be emailed to you in the coming days. So just so you know, my name is Megan Clark and I'm the Research and Evaluation Lead with the Saskatchewan Prevention Institute. And the Saskatchewan Prevention Institute and today's presenters from the Saskatchewan Health Authority acknowledge that we live and work on Treaty Land 2, 4, 5, 6, 8, and 10, and we acknowledge the various ancestral territories and the homeland of the Métis. We acknowledge the treaties of these lands and reaffirm the responsibilities and commitments to healthy relationships between Indigenous and non-Indigenous peoples. At the Saskatchewan Prevention Institute, we are committed to understanding the history of colonialism and playing a positive role in the important process of truth and reconciliation. So the presenters today include Derek Friesen. Derek is the FASD Assessment Coordinator based in Saskatoon. He has a background in behavioral science, educational psychology, and knowledge translation. He analyzes complex problems and bridges the gap between different stakeholders. His goal is to make FASD assessment more accessible and responsive to the needs of Saskatchewan families. Dr. Gita Wiebe is a developmental pediatrician based mainly in Saskatoon at the Alvin Buckwell Child Development Program. She is the division head for the developmental pediatrics and the physician lead for the SHA Provincial Autism Strategy. She is an assistant professor with the University of Saskatchewan. Her clinical and academic interests are in fetal alcohol spectrum disorder and the developmental and mental health needs of children and youth in foster care. And so I will just hand that over to you now, Gita and Derek, and I look forward to the presentation.
Thanks so much, Megan. Can you guys hear me okay? That's great. Thanks so much. I'm so excited to have been asked to talk with you guys today. And Derek and I are going to speak about the assessment and support of preschoolers with prenatal alcohol exposure. If there's questions, please put them into the chat, and I know that it's going to be monitored. And we've left enough time at the end to go through questions. We have our contact information at the end. So I know virtually doing this, it's hard to feel connected, and I'd love to connect with individuals that have an interest in this area and have further conversations. So we're hoping that this is an opportunity where we can connect further with people. So thanks for coming today. Neither Derek or I have any conflicts of interest to declare. I wanted to talk for a minute about positionality though. So some of you on the call may have heard about positionality and what that means, and what I mean by that is how our social position and power shape our identity and access in society. So as Megan had said, I'm Gita. I'm a developmental pediatrician. I'm white, I'm cis hetero, I'm able-bodied, and a second-generation Canadian settler. So for those that may be viewing this presentation in different ways, I have blonde hair, I'm not wearing my glasses today, and I'm wearing a blue shirt and a peach blazer. I'm sitting in my chair in my office at Alvin Buckwell, and you can see a whole bunch of stuff behind me because I forgot to blur my stuff. So I appreciate my position, privilege, and for being on this panel today. We're hoping to go through a few objectives, and starting from looking at the basic definition of FASD and how to recognize prenatal alcohol exposure and how that impacts the developing brain. We want to review the landscape of FASD assessment and diagnoses in Saskatchewan. So Derek's going to talk lots about that. And Derek's going to talk about progress towards a functional and forward-thinking model for FASD and what that means for assessment, diagnosis, and supports. I'll go through a little bit why we want to look at diagnostic assessments in preschoolers that have prenatal substance exposure, including alcohol. And then finally, looking at some of the challenges and strengths that an individual with FASD may experience. And then looking a little bit at the roles that caregivers and other support individuals have. So what is FASD and why is it important? So FASD, it's a lifelong disability that impacts the brain and body of people who are prenatally exposed to alcohol. We know that alcohol is an equal opportunity toxin, and it affects developing babies regardless of economics, ethnicity, religion, race, or societal status. And the complex challenges and life experiences that individuals with FASD experience leads to increased adverse outcomes, including involvement in the criminal justice system, mental health co-occurring conditions, and impacts as individuals age. And why do we care? FASD prevalence, and it's underreported, under-researched, and disparity in the research of populations that have traditionally been researched. Prevalence is 4%. When we look at autism, what that prevalence is, autism is 1%, cerebral palsy 0.21%, Down syndrome 0.14%, and Tourette syndrome 0.1%. So when you put all of those together, FASD has a larger prevalence. And when we talk about economic impacts and look at messaging, this is why it's important to have conversations like this. Oh, sorry. This has been extensively looked at in the literature, why FASD diagnostic assessment is important. And when the research looks at this, they've spoken with individuals with FASD, they've spoken to caregivers, they've spoken to diagnosticians, but most importantly, they've spoken to individuals that this affects. And when we look at the importance and looking at systems, looking how it mitigates development of adverse consequences, economic costs, families often report a sense of relief when they receive a diagnosis. And I think that's why I'm so passionate about preschool assessments. It's not a label, and that's what Derek's going to talk about, moving away from a label and moving towards function and strength, but also reframing and aligning supports and services to help with that function. Oftentimes, families will say it provides a sense of community and voice so that they can feel empowered to advocate for their child or for themselves. It can lead to better understanding of both an individual's strengths and areas of challenges, because each individual with FASD has unique strengths and unique challenges. We know that earlier diagnosis, and when I say diagnosis, I probably mean early identification of areas of unique strengths and areas of unique challenges, supports the development of fewer adverse outcomes later in life, whether that's medical, mental health, involvement with the justice system. There's strong research, not just in FASD, but in other developmental areas to support that. When we identify strengths, we help build that support around an individual, and we help build that support so that they can reach their full potential, and really so that they can engage in personally meaningful goals and expectations. And if we're going to be realistic, the top one that I have here is a mechanism for entry into intervention and support services. There's some provinces in Canada that actually have FASD specific classrooms, and those classrooms have demonstrated increased matriculation rates. So the number of individuals that are able and successfully graduate, because you're supporting an individual's strengths in areas that they need further supports in. In Saskatchewan, we don't have something like that, but when we talk about a mechanism for entry into intervention and support services, it also helps frame, for those that may not be aware of FASD, what FASD is, it helps reframe some of those differences that are there. What are the effects of prenatal alcohol exposure? And there's so many lenses that we could talk about for this, but I'm briefly going to talk about a developmental lens for this. We know that the timing and the dose of prenatal exposure leads to changes in the brain that are different. Most organs begin to form about 3 weeks after fertilization, which equals about 5 weeks of pregnancy. And most of the facial structures are formed in early pregnancy. So if we would have been having this talk 10 years ago, the different diagnostic criteria for FASD centered around specific facial features. And it's less centered around that now, because we know that despite having, let's say, early prenatal alcohol exposure versus later prenatal alcohol exposure, the function of that impact isn't any more stronger if you have it early versus later, because there's so many factors that impact the outward presentation later on. And we can talk about that more too if people have questions about that. But now there's less focus on those facial features. What I wanted to show here is the graph, the colorful graph where it says prenatal alcohol exposure. What I wanted to show on there is they've done studies, and what this is illustrating is in a population of children that have prenatal alcohol exposure, they looked at other adverse childhood experiences. So what that means is there differences, is there stressful life events that they have been experiencing in the womb or afterwards that could impact that developing brain. And what this is highlighting is only 1% of the children only had exposure to prenatal alcohol exposure. So there was 99% of the individuals had additional exposures, whether it was other substances, so polysubstance exposures, other stressful life events, and traumas. So when we're looking at seeing children that have prenatal alcohol exposure, we have to remember that that is usually only such a tiny little piece of the picture. And we really are doing a disservice if we're not acknowledging and respecting everything that's going on around that child to actually support that child as well. When we look at what stress does to change that brain in the early few years of life, what this is showing is that when you have early stressful experiences, early adverse childhood experiences, the stress causes the brain to form differently. So sometimes that means that actually, if you were to do a picture of the brain with an MRI, you actually see large differences that you can see on MRI. But even if you can't see those differences on MRI, a lot of the times there's still differences there that you have to do special imaging for. And that impacts outcomes as children age in different, what is called domains. And we'll talk about that. But what that means functionally and practically is that learning looks different and behavior can look different and communication looks different. So we'll get into that after. We know over time, and we've learned over time, that FASD is not just differences in the brain. It's also body-based, and it's impacted by so many different things like the social determinants of health, different intergenerational impacts and trauma, environmental adversity, and co-occurring health conditions. And we know that each individual has unique environments that they're in and unique caregiver experiences. There's still lots of stigma. Stigma just contributes to decisions about even talking about alcohol use, especially during pregnancy, and it increases fears of being judged or devalued by others. When we look at what clinics are doing across Canada, some clinics are moving towards looking at a strengths-based, function-based model in an effort to support challenges. So in some of the recent literature, when you look at the diagnostic capacity, it's astounding. This is actually from 2024, and they did an environmental scan across Canada and looked at all of the diagnostic clinics that responded to the survey. And what this is showing is that there was like 2% of individuals were able to access a diagnostic assessment. And the remaining percent of individuals, so 98% of individuals were misdiagnosed, meaning if an appropriate diagnosis would have been FASD, perhaps they were diagnosed with ADHD or anxiety or other things, or the rest are remaining undiagnosed. When they also looked in 2024, so this is a different article, when they looked at the challenges and strengths of the different clinics across Canada, one of the biggest ones is capacity, diagnostic capacity, having enough teams to be able to engage in this work, having enough system level supports, it's a big one, right? We know in Saskatchewan, there's other diagnoses that may be more visible to the political eye. So I'm not talking visible physically, but visible to the political eye that gain more support and more traction, and having system level supports to support diagnostics and care in this area is integral to having a successful clinic. Human resources is a big one. And I mean, it ties to diagnostic capacity. You also have to have adaptability. So there's not a specific formulation that you can follow. And you also have to have connections, especially in the prairies and Saskatchewan and a lot of different areas. There's different areas of provinces that have like location barriers and travel barriers to be able to access these services. And really we're looking at trauma-informed, culturally responsive approaches. So clinics that are engaging in these diagnostic processes, they've shared that this is one of the strengths. So that's really great to see. When caregivers were interviewed, caregivers have been interviewed quite often, but this is one of the more newer ones, and it really does reflect some of the system level barriers. And caregivers often talk about financial supports to be able to access these services. Shared leadership, meaning knowing that a caregiver knows their child best. So how do we involve that caregiver in the process and meeting people where they're at? Having the time and the support to do this, it's intensive. If you're going to do it and support families in an appropriate manner, it's not something that can be done within a kind of a typical clinic visit. And a lot of families don't have money in reimbursement for the expenses and the time that is needed to be able to do this. I hear time and time again from families, my doctor doesn't know what FASD is. They don't know how to support me. And this is true. This is true. When I went through medical school, we did not learn a lot about this. And this is why I jump at any chance to kind of have these conversations and try to engage and realign some of the medical education that when we're asked and have opportunity to do, because it is true. There's misunderstandings and it leads to more barriers and leads to more stigma. When they've talked to caregivers before and after receiving a diagnosis and in the process, some of the comments that are in the literature, some of the themes that come out is like, it's not even on their radar. It shouldn't be this hard to get an assessment and diagnosis and supports. And talking about sharing it with anyone that would listen, just so that when you advocate, trying to figure out where to advocate for that. And really and truly, when people say like, without the name, there is no place to begin. And in an ideal world, later on in the future, we really want to completely move away from labels and those diagnoses. And Derek's going to talk about that. But truly, when we don't have an understanding of it, then even labeling it leads to challenges. When they looked at clinics in 2022 across Canada, there wasn't a lot of clinics that were engaging in preschool assessments. There used to be a lot more clinics engaging in preschool assessments. And one of the main barriers is capacity and is supports and services to be able to access that. Where I trained in Manitoba, there was and is a robust preschool clinic, and supporting the clinic is kind of different system level access points. A lot of clinics that they also looked at don't follow the Canadian guidelines, and we're going to talk about the Canadian guidelines. And those guidelines have been around for a very long time. There's newer guidelines over the past few years, and they're revising kind of over time. And the guidelines really are with the spirit of supporting families and supporting feedback from families and what we see with the complexity and supporting the complexity. So in 2019, they looked at preschoolers and looking at the first assessment and why were preschoolers deferred? And what I mean by that is a preschooler comes in for an FASD diagnostic assessment. Okay. Why were they deferred? Why weren't they diagnosed with FASD? And so at the time in 2019, part of the guidelines were having growth face or brain abnormalities, and there was growth restrictions. So having a smaller head, being shorter, and being underweight. So that was part of it used to be part of the guidelines. What was interesting about this is executive dysfunction was almost universally present in the preschool age. So what I mean by executive dysfunction is that frontal part of your brain that helps you plan and organize and move from one activity to another in really a regulated state When you think about preschoolers and being in structured environments or being in play environments, that is really integral to being successful in a community. And when you have emotion regulation challenges and executive dysfunction, that really impacts functionally success. And they found different areas of the brain already were working differently. So even though not meeting criteria, you're having significant differences in the way that you're moving your body, in the way that you're understanding people, and the way that you're remembering things. And already there was areas that were challenging for kids. What they did after was look at, okay, we didn't diagnose. We want to see you again after time. And the majority of kids were diagnosed afterwards. And what made, I guess, the diagnosis clear was the degree of brain impairment. So that means we're going to talk about the different domains that you see in FASD. And it was more apparent. And my concern with that is we're already seeing that in the preschool age. And that's why those that have clinics that see children that are prenatally alcohol exposed, we know that the more therapy and the more supports that a child gets when they're younger actually leads to better outcomes. So when we're already seeing that, even though you don't need a label, we know that there's supports that are needed. And also, striking here is that like 85, almost 85% had not just a diagnosis of FASD, but actually had comorbid diagnoses, whether that's in the mental health realm, like ADHD, anxiety, a medical diagnosis, or perhaps an intellectual disability in that area. So I think I'm going to hand it over to Derek. I'll see what the next one is. So Derek's going to talk about preschool FASD assessment in Saskatchewan.
Absolutely. So I am Derek Friesen. I am a white male presenting person living in Saskatoon on Treaty 6 territory. I've benefited from generations of unfair privilege in society. I appreciate Geeta's wonderful and succinct discussion of FASD to this point, and I'm going to talk about how some of that translates to a Saskatchewan context. In my work for the Health Authority, I wear a couple different hats. I sometimes take a top-down provincial level look at FASD services, and then I sometimes am looking at a bottom-up clinic level. I'm going to talk a little bit from both of these perspectives, but really focusing on the early assessment in Saskatchewan. Early assessments for FASD in Saskatchewan are in an emergent phase. The landscape in Saskatchewan for preschool FASD assessments is fairly fragmented and faces challenges right now. While there are services like the longstanding LaRange Outreach Clinic and the more recent preschool team here at ABCDP, access remains limited, particularly to rural and remote areas. The scarcity of services that meet families close to home and the long wait times further compound the difficulties that families face in obtaining timely assessment. So from that provincial level, a question we need to address is how can we enhance access to early FASD assessments for children across Saskatchewan so we can ensure no child is left behind due to geographic barriers or resource limitations. Again, I want to highlight that point of a long wait times. So right now, ABCDP is the only dedicated preschool team in the province. The current average wait time for children 5.5 and under is about 11 months. There are some practitioners across the provinces who diagnose. I would be remiss to not mention Dr. Pat Blakely, who has done very good work for a long time up in the LaRange area, working out of northern ESIP North. But since April 2021, the preschool clinic out of Alvin Buckwald has been the primary preschool clinic operating in Saskatchewan. There are discrepancies as well in public support. Geeta touched on this a little bit. So there's a lack of equitable access to resources for families and individuals with FASD in the province. If you could go to the next slide there, Geeta, would be great. Thank you. So yeah, the demand for preschool FASD assessments at ABCDP is substantial. And so this is part of what creates these significant wait times. Our current resources allow for about one preschool FASD assessment a month. And our current wait list has about 18 children, 5.5 and under, again, waiting an average of 11 months. Delays between being referred and having an assessment can have detrimental effects on children's development and well-being, as Geeta mentioned. Therapy blocks at ABCDP can be available to children who are accessing its service until a child enters school age. So this is one thing that underscores the urgent need for increasing capacity and streamlining our processes to get people access to early assessments for all kids in Saskatchewan. When I say all kids in Saskatchewan, I mean that preschoolers from across the province are triaged to ABCDP, and you see that on this map. This is just a sprinkling of the referral area that comes into ABCDP. We get referrals from family doctors, from nurse practitioners, locum clinics. A few referrals come from the NICU or at the time of delivery. The majority of children on the waitlist right now are from outside of Saskatoon. And again, I want to emphasize the complexity of FASD and the frequent presence of co-occurring conditions like ADHD, anxiety, and learning disabilities. These co-occurring conditions complicate the assessment and diagnostic process, as Geeta said. Could we go to the next slide?
Yeah,
yeah,
I have a couple. Yeah. So I had looked back. We started the clinic in April 2021 unofficially and looked at how we could more intentionally look at providing a diagnosis if that was appropriate for families. And when we started, since we started, there's been 30 kids that have been seen. And I look back at some of the statistics, and just over half of the kids we've diagnosed as at risk. And what that means is they're at risk of developing FASD. The literature supports that you can diagnose about just less than half of kids in the preschool age range with FASD. But what I found striking about this is 87% of kids already in the preschool age that we saw presented with a complex neurodevelopmental difference. So what I mean by that, and I'll get into it, is something like, yes, they're diagnosed with at-risk for FASD, but we were seeing functional impairments with diagnoses supporting autism, ADHD, anxiety, global developmental delay. And those are important to help conceptualize a child's areas of strengths and areas that they need further supports in, especially as they're transitioning into pre-K or to school or whatever environment they're transitioning into. This other area, when we first started, we hadn't had the ability to look back and ensure that a referral still remained relevant. And we've made strides in that area. And so what I mean by relevance is, and Derek's going to talk about this, but looking more at a function forward model and looking at a child's family's goals and areas that they are identifying as concerns. But when we first started the clinic way back in 2021, there was actually a few kids that had typical development, and we know that just because a child has prenatal alcohol exposure, that does not equal that you have FASD, or does not equal that you have developmental differences. So I think if we were to do this again in a couple of years, we would see some differences there. For the children that were diagnosed with FASD, there was almost all of them had complex FASD. And what I mean by that is having FASD plus global delay, FASD plus autism plus global delay. So I don't like the word salads, but what we're trying to convey is that the level of risk for co-occurring conditions and the level of supports that a child would benefit from are significant. And what we're demonstrating here is demonstrated across the country, that just because a child may not meet a diagnosis or a label, that is not accurately conveying what the complexity is going on there. So in the children that we diagnosed as at risk, so over half of them had complex co-occurring conditions. And again, like the most common ones were autism, global delay, ADHD, other conditions.
So jumping again back into this sort of province-wide perspective, assessing FASD in preschool-age children is inherently challenging. The intricate nature of the assessment is compounded by the geographic barriers, resource scarcity, and the long wait times. And this creates significant obstacles for families seeking this assessment. As well, the discrepancies in available supports and the lack of equitable access to services exacerbate the challenges in assessment. So the emotional and psychological toll of families navigating the assessment process cannot be understated. Some of the specific challenges faced by families, especially in rural remote areas, include long travel distances, lack of transportation, and limited access to specialized services that are available in urban centers. More generally, there's accessibility and communication barriers, including a lack of understanding about the assessment process. Resource constraints include shortage of specialized professionals and teams or administrative support, coupled with long wait times, and this creates frustration and delays. So the assessment process itself can be overwhelming for families who are already in crisis. And from a clinical side, practitioners can grapple with burnout due to the administrative burden and the resource limitations as well. I have a big list of details on these barriers, but I think in interest of time, I'll skip forward to the next slide. So despite those challenges, there is hope and a path forward. Emerging research and practice across Canada indicate a shift away from a solely diagnosis-focused approach towards early support and intervention, regardless of what that formal diagnosis looks like. There's innovative approaches implemented by clinics like at the Manitoba FASD network, the Mackenzie Health Clinic in Toronto, the Lakeland Center for FASD, and the Glenrose Rehabilitation Hospital in Alberta, and others are emerging. Some of the practices include mobile assessment clinics, telehealth assessments, and spoken hub models that bring services closer to home for families. So one thing we've been working on a provincial scale is trying to learn from the best practices from clinics that are doing this important work and adapting them to the Saskatchewan context so we can make significant strides towards improving the landscape of preschool FASD assessment in the province. Most importantly, for assessment and diagnosis, multidisciplinary teams are part of the process for investigating and supporting developmental function. And this happens in tandem with the process of gathering evidence for a diagnosis. When we talk about assessing in terms of developmental function, this means that the assessment and diagnostic process should focus on the child's actual abilities and the challenges they face in everyday life, rather than solely relying on the standardized tests or comparisons to typically developing children, with a goal of understanding how children function in their environment, including their strengths and weaknesses. And this can help tailor interventions and support their development. A multidisciplinary team is key here. And for Alvin Buchwald, that means like beginning to include professions like speech language pathologists and occupational therapists in that early assessment process, because these specialized professionals can offer more specific and tailored advice to help meet kids and families where they're at in terms of the help they're seeking. Now, this is not to diminish the value of diagnostic labels. Geeta gave a great conversation about why those still have value and why we're not seeking to usurp those. Instead, in the Saskatchewan context, investigating by function aims to assess the needs of these children from the ground up and from the family's perspective. Ultimately, it is my hope to seek balance between the diagnostic labeling and supporting developmental function. Hopefully, by adopting functional approaches like this, like other clinics across Canada are doing, we can provide tailored interventions and support that empower children to thrive regardless of what they are referred for. If you could go to the next slide, Gita, that would be great. So this slide kind of raises the question that I get asked a lot in this position, which is, why is a diagnosis dependent on reported use of alcohol? There's lots of different reasons. So FASD is said to be a known etiology in terms of being a developmental disorder with a known cause. And valid report of this known cause from a diagnostic perspective is considered strong evidence. There's an idea that alcohol does not discriminate, in that alcohol doesn't affect different fetuses differently. But one thing to consider is that other developmental risk factors also do not discriminate. The confirmation of prenatal alcohol exposure can point to functional areas to investigate, and this can be used to differentiate FASD from some of the other complex developmental differences. So having that evidence of PAE might make the difference between a child being misdiagnosed with ADHD versus qualifying for that diagnosis of FASD. From the other side, there's the question of, do we hold these same standards for making a diagnosis for other developmental diagnoses? And that kind of, we're trying to understand that seeking evidence of prenatal alcohol exposure can be difficult. It can be shaming, stigmatizing, and it can complicate assessment efforts. As well, there's a big question of how we establish the validity and the reliability of PAE confirmation. While diagnosis is important, again, I kind of feel our ultimate goal should be to balance that diagnosis with the developmental function of all children with concerns of prenatal alcohol exposure. And again, I just have the slide in here just to emphasize that the traditional reliance on reported alcohol use for the diagnosis warrants a bit of critical examination. Again, this approach can perpetuate stigma and inequity, and it places the burden of proof for a diagnosis on the families, and problematically may exclude children who don't have access to reliable exposure information. And we don't want kids who don't have strong evidence of alcohol exposure to slip through the cracks in getting supports for their developmental needs. So by challenging the status quo a bit, we can prioritize child's needs and ensure that all children receive the support they deserve. You could scooch on to the next one. That would be great. Aligning with the best practices to achieve our goal of supporting some of these developmental functions, it's imperative to align our practices with the established best practices in FASD assessment and diagnosis. This includes active involvement of caregivers, timely accesses to services, streamlined processes, and clear communication. So by adopting a family-centered and collaborative approach, we can empower families and try to optimize outcomes for children with FASD. Again, involving professionals such as SLP and OT in early assessment can provide more targeted recommendations. We want to emphasize the importance of involving caregivers in every step of the assessment, from referral to diagnosis to connecting with supports. I feel caregivers and patients' needs should guide and inform the assessment process. In my own experience, families are often seeking access to tangible and functional supports and see the diagnostic label as a step towards gaining some of that support for the functional needs in their everyday life. Could we go to the next slide? That'd be great. Thanks, Gita. Some of the goals for preschool FASD assessment. Our vision for increasing the capacity for future of assessment in Saskatchewan, it's ambitious, but it's achievable. I aim to increase capacity for early assessment, partner with community organizations, improve our referral process and use some approaches in terms of data and resource management to achieve these goals. I want to kind of emphasize here the importance of partnering with community organizations to bring that assessment and diagnostic capacity closer to home for rural and remote patients. This is an approach that we see done very well in some of our neighboring provinces in terms of assessment and diagnosis for FASD. So we can look at Manitoba, where they have a really excellent spoke and hub model for assessment, where they have one major center with resources moved out to community hubs. And then we can look at the network of FASD support in Alberta, where they have a provincial level FASD network with clinics across the province that are better placed to meet clients in their community. These are strategies we can learn from as we try to increase our capacity. If we can go to the next one, that would be great. Oh, this might be you?
Yeah, apologies. I actually added this last minute, which is why Derek was like, so as we move forward, when I was looking at the information that Derek had there, how do we move forward in kind of bringing all of this together? And as practitioners, one of the areas is looking at our own biases and how that impacts diagnoses that we actually consider. So we know that disproportionately marginalized populations and Indigenous populations are referred and assessed for FASD, whereas other populations may be referred and assessed for ADHD or autism. And so how do we advocate for that, for systems of care across all communities, when we know that not all kids with the same diagnosis will actually have the same functional needs? So an easy metric that health ministers and other areas look at is how many kids were diagnosed. That's an easy one to look at, but we know that a child diagnosed with FASD, their unique profile is going to be different than the same age child across the street from them, right? And that spans not just FASD, but autism, but other developmental differences that we see. And we know that different developmental diagnoses can have the same functional needs and could benefit from the same services. And there is a huge disparity in access to supports and services. So I just added that as when we move forward, looking at how can we make a system change.
Okay, so now I'm going to briefly kind of speak about kind of existing preschool assessment pathways here at ABCDP, kind of the steps it takes, and a little bit about what to expect if you're seeking assessment. Let me see. So the process here involves several key stages, from referral and intake to attending clinics and receiving information about the diagnosis. Different information is gathered at different steps. And part of my role is to improve the support we provide families throughout the process. I have each stage of the step here written out, and I'm just going to kind of summarize it a little differently. So the process begins with a referral, likely from a doctor or other healthcare professional. The client gets added to the wait list, and we attempt to contact the family to confirm interest in the assessment and gather information. Once the family is ready to proceed, we obtain consent. We begin gathering school reports, other relevant information, questionnaires and forms. Lots of these are part of composing histories that can be valuable in the diagnostic process. As information comes in, the team reviews information and determines the appropriate assessment type. So that means who's involved in the assessment. Once we have as much information as we can, a family is contacted to schedule the appointment. Again, the assessment might involve multiple appointments with different professionals. For people who live further away from Saskatoon, that might look like a virtual interview at the start, just in order to reduce the need to travel into our clinic. And one thing we're working towards is kind of, especially for preschool children, trying to utilize some of the other professionals we have here at ABCDP, including SLPs and OTs, who specialize in some of the areas that we're looking at when we're diagnosing FASD. Following the assessment, the team reviews the findings from the forms and from the standardized assessments and determines if a diagnosis is appropriate. We inform the family of the results. We talk through a report, and then we recommend support and services. It can be a lengthy and complicated process, with wait times between 11 months and sometimes 2 years. We have ongoing efforts to improve the efficiency and timeliness of assessments. We want to be flexible and accommodate the individual needs of families. And we want to maintain clear communication and collaboration with families so that they can inform the direction that their assessment takes. If you could skip to the next one. I just wanted to talk a little bit again about bringing it back to that confirmation of prenatal alcohol exposure here. Confirming prenatal alcohol exposure can be challenging, especially in the absence of a first-person account or reliable third-party information. So from a diagnostic perspective, an ideal quote-unquote scenario involves clear documentation of alcohol use during pregnancy, but this is often not possible. In many cases, we can utilize the best available information that we have, while acknowledging the potential for bias in the process of seeking that information. From the diagnostic guidelines that were published by CAN-FASD, the account of alcohol use that is closest to the birthing parent is generally considered most useful for a diagnosis. We want to consider the importance of using third-person accounts and other forms of evidence like medical records and social histories. Again, these can be sensitive discussions. There can be stigma loaded into these conversations, and we don't want to create distress when we're seeking this information. It's important for us to adopt a really trauma-informed and culturally safe approaches when we're seeking this information. And in some cases, maybe this information doesn't even come up when we accept a referral, or maybe a child is referred for something that isn't FASD. But then as the family gets to know our team, maybe that information comes out. We are working with an ABCDP to better define our pathways of how children are diagnosed based on functional need. And that kind of goes back to some of the conversations we had. And now I'll give it back to Gita.
That's great, thanks. I'm going to go over a little bit in the research about can we predict FASD diagnosis in preschoolers. There's been lots of work on this, and what I'm wanting to show here is that you actually can predict the eventual diagnosis of FASD. When you look at impairments in motor skills, pair it with impaired language, using comprehensive language assessments and looking at sensory impairments, they're a significant predictor for development of FASD and really support the neurotoxic effect of alcohol. So you see that even in absence of classic dysmorphology. So what I mean by that is absence of typical facial features that we see in FASD that I'll go into right away. When we look at assessment of preschoolers with prenatal alcohol exposure, there's several different areas that CAN-FASD suggest in the guidelines to look at. And this is why we have the team members that we do. We look at communication, motor skills, we're looking at informal problem-solving skills and sensory processing. Sensory processing actually isn't in the newest guidelines, but I had the honor of training underneath one of the individuals that informed the original guidelines and trained in the area where my mentors were informing the next guidelines, and there was a lot of controversy with not having sensory processing as part of the new guidelines. And so a lot of clinics actually still include it because it has functional information that's important. And then we're looking at executive functioning, adaptive functioning being everyday living skills. When you look at risks, benefits, and looking at capacity issues, the literature really does support looking at that early assessment, implementation of early interventions. When you are not accurately identifying a child's developmental profile at an early age, that could limit their developmental potential. And Derek touched on timely referrals, looking at how can we see these kids sooner. And there's been lots of work looking at a more functional approach. So the therapist seeing first before the diagnostics, and how can we support that function and not focusing so much on the label to try to decrease that gap between identification of a concern and a possible label or diagnosis. There's lots of literature out there that looks at why wouldn't we do this in the preschool years, because when we say that you can diagnose about half of children, that still means that there's children that can't be diagnosed in their early years that may be diagnosable later on. And that has to do with ever-changing brain physiology, the development, the rapid change. Some of the areas that we look at can't actually be directly measured, and some of the areas have to be evaluated using questionnaires. And when you look at questionnaires, there's a lot of implicit bias that can happen with questionnaires, and a lot of barriers to accessing questionnaires, language level, language that we offer it in, internal biases that individuals may have, and even just having the ability to complete the questionnaire without having someone maybe support that. When we look at early life adversities, we know, back to that diagram where it was only 1% of children only had prenatal alcohol exposure, 98, 99% of children are going to have additional early life adversities that impact a presentation. So there's hesitancy in some circles to make a lifelong diagnosis in the preschool years. That would be lifelong later on. But what we're looking at is prevention of adverse outcomes. So really, if we're recognizing that there's a functional impairment, we want to recognize that, and we don't want to delay assessments, having service availability, having to qualify for service, starting those services. In the world of someone's diagnosed with something, there's wait lists for everything. So in the world of I'm now diagnosed with something and now I actually want to get supports and services, there's going to be wait lists for everything too. And when we talk about maintaining services and what the barriers are to maintain services, where I've often encountered families where their child has FASD, they received a diagnosis in the preschool years, they transition to school, they're doing really well in school, they have supports, they have services, and for a multitude of reasons, then it's trying to figure out what supports and services do they still need. That developmental profile has changed over time, and so having that understanding of what that looks like 2, 3, 4, 5 years later, even months, right? Because that profile, even though we know remains consistent with FASD, that function and those needs change over time. And what caregivers will say is we need to be more aware. And I encounter a lot of caregivers too that will say, like, yeah, I've lied. I'm said that their child's autistic, right? Because people understand that more than my child has FASD. What are we also trying to do in the early school years is we're trying to look at the development and all of the impacts on that development. You can't negate that development is impacted by environment, by society, by genetics, by all of that. And so we want to take that all in and look at the risk factors and look at how can we practically help. And it's a journey. It's not something that happens within 5, 10, 15-minute clinic visit. Typical referrals to preschool FASD diagnostic clinics include concerns regarding emotion regulation, attention, development in general, so delays with just milestones in general. When you look at the different ages of preschool FASD and what some of those early quote unquote signs could be, it's different depending on if you're an infant, if you're a preschooler, and what is different about that. And when we hear caregivers talk about it, it's more so about the reframing, right? They're not bad kids, right? I often have caregivers say they've been labeled as a bad kid. They're not allowed to go back to school, and it's a misunderstanding between what a child's ability is in that moment and what supports we need to put in place around that child to support them. So the most recent guidelines were published in CMAJ, and when they talk about the different domains, there's 10 different brain domains. It's not, domains aren't specific to FASD because everyone has these different areas in their brain development. And when we talk about motor skills, that's how like our muscles move, how our muscles act. It's looking at balance, reflexes, coordination, looking at the way our brains are made up in anatomy. So earlier on, I talked about how you can actually, there can be structural differences in the way that brain has developed depending on when that prenatal alcohol exposure was. So you can have smaller head size. Some children have seizures. That brain structure can be different. Your problem solving, your cognition, not all children that have FASD have an intellectual developmental disorder. Many do, not all do. And there's a big misunderstanding between like what functionally that looks like. Communication impairments are very common. And as we learned earlier, that's actually one of the largest significant predictors of having FASD, and the communication profile looks different. I work closely alongside speech when I trained in Manitoba, and in their early years, having impairments in your understanding of language, but being very verbal is very common. And so oftentimes kids are misunderstood and thought to really be understanding what's going on around them, but they really don't understand. And as that gets older, that can turn into confabulation. So making up stories to fill in the blanks, because you also can have differences in your in the way that you remember things, so your memory, and in the way that you learn. So academics and looking at math and reading and writing, there's different profiles that we see in children for that, and in your memory. So just like your immediate memory, remembering things that are just told to you, but actually your memory for events that happened in the past as well. Attention is one of the earliest signs that we can see differences in attention. Differences in that executive function. So that planning, that organizing, that going from being able to successfully transition from one activity to another in a regulated state. And one of the new areas in the newer guidelines talks about affect regulation. So that's really getting at how one's controlling their emotions, reacting to stress. Everyone reacts differently to that stress. And they've included certain diagnoses underneath the affect regulation because they're just so common in FASD. And everyday living skills. Even if a child does not meet criteria for an intellectual developmental disorder, we often find that those everyday living skills are lower functionally. And that's very important as children age into adolescence, into young adulthood, looking at program planning and jobs and what does that look like for them for success. So in Saskatoon, the core team members look a little bit different than the CAN FASD suggestions because of capacity and because of availability. And what we're really hoping and wanting to do is when we see a family, we want them at the center. We want the family at the caregivers, whoever it is, whoever's important in that child's life, we want them at the center of everything. So they're at the center and things flow from there. And we have speech, language pathology, occupational therapy, clinic coordination, medical social work, and myself as the physician. So traditionally the roles of intake or social work or coordination is really acting as the first point of contact. And every clinic across Canada has different individuals in these roles. As Derek mentioned, the clinics across Canada that are more visible and have received more system funding have different hubs and spokes and different coordinators in different areas to form those relationships. And this is the key. This is the key to having a successful successful interactions and successful outcomes is having relationships and having those individuals that can form those relationships, and meeting families and kids where they're at, and understanding. That's the only way we can understand strengths and really what caregivers and children want. Occupational therapy has so many different roles, and it goes from looking at functional skills to sensory profiles, to looking at learning styles and play skills, social skills, attention, looking at all those different influences for a child, on a child, and looking at those complex behaviors. We do find that fine motor delays are present more so than gross motor delays. If there's a gross motor delay, likely there's going to be something like global delay that is identified more earlier on. But the occupational therapists that are involved look at the person and the impact of the environment. As you saw before, we have seen, probably more so in the past year, a lot of children that either have FASD plus autism, or the question is, does this child meet criteria for a diagnosis of FASD? But we find that they meet criteria for autism. And 10 years ago, those symptoms, we know that they overlap, and there's different reasons for having those areas of differences in their behaviors and in their play. There wasn't a lot of comorbid diagnoses in my training, but now finding more and more that children are meeting diagnoses. And the reason why we would make a comorbid diagnosis is to help understand better where supports and services may best be focused. So the role of the speech language pathologist is so key as well, looking at language, looking at social communication, and really informally looking at attention, activity level, behaviors in general. And when you have challenges with your understanding and your expressive language, very strong predictors of an FASD diagnosis. And the different tests that are used, some of them can actually underestimate the challenges. And my therapy colleagues aren't here, and I don't want to speak for them, but I know that when we spend time with children, one of the challenges is as well as managing behaviors and managing emotions of during that assessment process, and supporting children so that we can understand them better during the clinic process. And so there's lots of work that's been done to try to figure out how can we support families through that. One of the biggest things that I hope over time is that we do move towards a function strengths-based approach. And there's lots of work out east that talks about this. It originated in cerebral palsy research, but there's lots of translation looking at how can we talk to families about function. And I won't go into detail, but they used to be called F words. I think some people have recoined it my favorite words because it probably sounds a lot better. But what we really mean about this is actually looking beyond a label, looking beyond a medicalized disorder framework, and shifting and looking at what's important to this family, to this child. Who are their friends? What do they do for fun? Who's their family around them, looking at what activities they're involved in, because really, as children age, that's the practicality, right? We want them to engage in goal setting, and families too, and we want to make sure that we are meeting families' needs. So the role of the physician in different clinics does look slightly different. I often find myself doing a medical history physical exam that's systems-based, but looking at the development, looking at developmental assessments, and looking at differential. I'll always remember one of my mentors that actually was part of the first guidelines had some facial features that would be similar to the sentinel facial features you find in FASD. And he would joke about this, and he did not have FASD, right? But when you see similar facial features, that doesn't always equal prenatal alcohol exposure, which is why we need to be very careful and very respectful that if we don't have documentation, this isn't a diagnosis that we should be exploring, because there's lots of different genetic differences. There's lots of different there's just lots of different faces. And the only time we know that it's very, very diagnostic is in a newborn. So if I were to see a newborn and they have all of the sentinel facial features and we don't have documentation, that would be the one time with a small head size. That would be the one time I would make a diagnosis. But other than that, it shifts and it changes as individuals age, and it's not as specific as you get older. So these are the facial features that I'm talking about. So these are some of the tools that we use. Clinics are investigating what you can use for photography. Lots of clinics are using photography so that you can support remote assessments and have clinics, local clinics, do a photography, and the measurements then are standardized and you have them, and it's not prone to human error. And we're looking at different other facial features as well, but we're looking at the lip, the philtrum, and then the palpebral fissures, so the between the eyes. When we're looking at the impacts of FASD, different individuals in healthcare become involved over time, and we have Dr. Mila in Saskatchewan, who is a forensic psychiatrist, and he's really the father of forensic psychiatry in Canada. And he has done lots of work in the adult population with FASD and looking and mapping out different areas of co-occurring conditions and different areas of supports when we talk about psychosocial supports and talk about medical supports. And when we look at mood regulation, hyperarousal, adaptive functioning, it all is part of a profile, and it's very individual and it's very specific to each individual. But knowing the different areas that can look different supports how to move forward. There's a group of individuals, they're called the change makers. So there's a group of individuals that have FASD, and they published a survey a few years ago, and they were looking at comorbid medical conditions. And this just wasn't in the literature. And now it's really going to take off. There are so many comorbid medical conditions that adults with FASD will say that they are encountering healthcare with. And it's just not something that was understood 5-10 years ago. And even now, when I'm seeing younger individuals, I'm talking to them about, do you have pain? Do you have chronic pain? And the more that I'm asking, the more that families are sharing about pain, about recurrent ear infections, about constipation. And so when we talk about FASD not being just a brain-based disorder and it's a whole body diagnosis, that's what we're talking about. We're also talking about mental health co-occurring conditions. ADHD is one of the most common co-occurring condition. We even see that in the preschool years. So this study is looking at kind of all age ranges in the pediatric age range. It's not just focused on preschoolers, but what's concerning about that is when we see preschoolers with FASD, this is what we're trying to support and mitigate, because we know the less support you have, the more at risk you are for mental health challenges. And this psychotropic medication algorithm is actually authored by Dr. Mila and his team. It's rigorously researched and identified that there's different areas of symptoms as you get older that may be of benefit to help with different medications. So individuals that are involved in following older individuals with FASD, this has been really, really helpful and just such a game changer. What do caregivers want us to know? I think the biggest one is they want people to be FASD informed. And I think we're just preaching to the choir right now. I would suspect everyone on this call is FASD informed, but breaking down that stigma and being FASD informed and really recognizing goodness of fit. Not all physicians, not all therapists have goodness of fit to support individuals with FASD, and recognizing every person with FASD is different. Yeah, and never dismissing an individual's feelings. I think that's a big one. I often have families share with me their experiences in an acute care medical situation or in other situations where there's a lot of misunderstanding and a lot of stigmatization and a lot of shame. Derek mentioned this, and I think we have a call to action to realign our focus to become more trauma informed and realign for strengths-based services and incorporate more culturally safe services. So I think that's one of the things as a clinic we're wanting to explore some more. And in the end, caregivers want us to know that their kiddos are friendly, they're generous, they're autistic, they're musical. Almost every time I see someone in this, I'm not trying to label this, but I'll hear story after story about how their child is having strengths with visual motor, so putting something together, very visual, able to manipulate, and you can just see kids light up when you talk about what their areas of interest are. Athletic, determined, hardworking. I mean, this is all amazing things, and really finding your strengths and your weaknesses, and don't be ashamed. Because once you know what you're good at, then the world is yours. So what we want to do is one of my calls to action is look at, is there other provinces that are doing preschool FASD assessments, looking at what are other centers seeing, looking at how we can develop an Indigenous approach to FASD and engaging with other stakeholders and individuals with FASD. Individuals with FASD would be the most important. So what we wanted, hopefully, to get across is that early diagnosis and interventions, they're positively correlated with better long-term outcomes, regardless of a label. When we look at comprehensive assessment in the preschool years, we want to be supporting strengths, not supporting a label, not just discharging families. And the reason for that is when we're looking at function, that plasticity, those synapses are just most malleable to change in those preschool years. And preschoolers with prenatal alcohol exposure and concerns about their development, they can be referred to Alvin Buckwald for consideration for assessment or underneath the different pathways that we have at Alvin Buckwald. So Derek has put his information up here. If you're looking for assessment, interested in collaborating, please get in touch. And I put my information there as well. And I think that's it. So thank you guys. Thanks for listening. I'm just going to put it back on that one. And that's the end.
And I'll just pipe in as well on this slide with my information, especially if you are a coordinator, if you do work with people with FASD in the province and you're interested in being involved with assessment and diagnosis here. And I'm really looking into developing as many creative partnerships as possible, just to try and get services and connections closer to home for families who are seeking this assessment. So please reach out to me if this is something that your organization want to be a part of.
I'll just jump in here and say thank you so much to both Dr. Weeb and Derek for your very informative presentation and for sharing all of your knowledge with us today. Nobody has put any questions in yet. If anybody has any questions, please feel free to put them into the chat, or if you raise your hand, perhaps we could unmute you. I think that's possible. I guess if no questions come, I do have one myself, if you don't mind. So one of the things you talked about definitely is the fact that children, often FASD is only part of what they experience, that adverse childhood experiences are a big part of that. And I'm just wondering, what sorts of supports are there for preschool children at this point in terms of, maybe supporting the families themselves or supporting the children around those sort of other factors that are impacting their functioning and mental health?
I might jump in first on this, and then if Gita has anything to add, especially at the preschool age, with the pathways here at ABCDP, one of the best things we want to do is get those referrals in, and again, have that therapies first approach, just to have kids in the door so they can get access to these services that we provide until kids are school age. In the province, when kids are in that school age, some of those services are provided by the school system, who are equally resource scarce and have equal wait lists. So in terms of things we can provide, it's great to have. I really want to shout out the FASD network, which is language nationally for FASD networks isn't consistent. So in Alberta and Manitoba, the FASD networks are publicly funded bodies providing services. Here, it is not funded, or it is not in the same way a public organization, but I think they're doing really good work with that client-facing support in terms of getting grants for like youth and family groups. And one thing we're looking at with them as well is eventually hoping to partner with them more directly in terms of supporting families through assessments. That's just in initial stages right now and just conversations we've had informally, but they're great for that. And then as well, and with them, it's important to highlight that you don't need the diagnosis to access their services. So if that's something that you or your family is struggling with, you can contact them and they can work on setting you up with support workers. But this, again, it does kind of circle back to the idea of inequitable access to services. So there aren't the same funding opportunities for children just diagnosed with FASD versus kids maybe diagnosed with ASD or other services. So there's an important advocacy level that we working with people with experiencing FASD have to make it clear to policymakers in Saskatchewan that that is a need for families who are experiencing this. Gita highlighted well that FASD does very rarely occurs in isolation from other developmental disorders. So sometimes we see those supports for FASD attached onto supports for other services. So, for example, maybe a child is diagnosed early at risk for FASD, but also comorbid with ADHD. And that might look like in school, the child is getting an EA for the attention problems, but then that educational assistant is still providing support for the other functional areas that come along with the FASD at-risk diagnosis. So we see those services as informal attachments to other services. So definitely a big question, not just in Saskatchewan, but in the in Canada writ large. I see Gita's unmuted, so I'll let her speak as well.
I agree with what Derek said. Megan, thank you for the question. I think practically in the preschool years, that's why OT, so occupational therapy and spatial language pathology, are so integral to having an understanding of the child and understanding of what the caregiver goals are. More common reasons for referral are emotion regulation challenges, sensory differences, delays with development in general. And so it depends on what the family's goals are. If emotion regulation is one of the goals to work on, it practically would look like working with occupational therapist and working on supports and strategies for that. And that can be in an individual setting, in a group setting. The therapists at Elvin Buckwald have been seeing kids with prenatal alcohol exposure and medical complexities as the tertiary care center for a long time. And so, yes, some of these things are specific to FASD, but a lot of them actually translate outside of prenatal exposures. A lot of it has to do with early adversity as well. And depending on the circumstances, we know of areas outside of Saskatoon. So if you're in Saskatoon, areas outside of Saskatoon, when there's individuals that have play therapy, for example, or engage in parent-child interaction therapy through psychology, whatever that goal is, if it's communication, if it's social communication, working with individuals that have expertise in social communication and working on those supports and skills. Sometimes it looks like being in a pre-K program environment or a daycare environment, advocating for inclusion supports, inclusion grants, having an individual like supporting them there. Outside of Saskatoon, like Derek said, many of the referrals that we get are actually outside Saskatoon, right? So it's not Saskatoon centric. It's just we're one of the only areas that would do the diagnostic piece assessment. But again, that function and those supports, there's so many people in Saskatchewan that have that expertise and have that ability to support families, but its capacity and its access as well. The publicly funded services for preschoolers have long wait lists. Yeah.
One final building block off that as well is again, so the complexity and the pieces needed to compose that FASD assessment and diagnosis make it can create it, can make it so it takes a long time. And sometimes families are seeking support that are more immediate or for issues that don't, that come before the diagnosis happens. And so again, in this way, we see services for families happen in informal ways rather than as a product of the diagnosis itself. So again, that's not just Saskatchewan, that's Canada, and that is an area for advocacy and development. And again, putting out that call for anyone attending who does this work and wants to formalize pathways. If you work with people who are concerned about prenatal alcohol exposure, who are interested in assessment, or if you provide services and are looking for people to provide services to, love to partner with you. So please reach out.
Great. Well, thank you. It doesn't look like anyone else has come up with a question. So unless there's anything else that you wanted to add, I just have a few comments to make to wrap things up. Okay. So again, thank you very much, both Dr. Derweeb and Derek. This has been really informative. And thank you all for joining the webinar. When you close the window to the webinar, you will be directed to a link where you can complete a short evaluation survey for this session. And completing these evaluations help us to create programming and resources that support you in your work. So we really appreciate the time it takes to complete. It'll be very short. So I guess that's it. Have a good day. Bye-bye.